My name is Alex Enriquez. I talk about comprehensive molecular characterization of papillary renal cell carcinoma. Definition: a type of kidney cancer that forms in the cells that check the small tube in the kidney that filter waste from the blood and make urine. When viewed under a microscope, most papillary tumors look like long, thin finger like rods.
Papillary renal cell carcinoma is the second most common subtype of renal cell carcinoma. The most common is clear cell renal cell carcinoma. Papillary carcinoma usually shows predominantly papillary architecture, and it frequently has well-formed fibrous capsule. In this part of the picture we can see residual renal parenchyma. Here we have perirenal adipose tissue and this large papillary mass. This is papillary renal cell carcinoma. Here we have the fibrous capsule of the tumor, which is usually lined by the epithelial cells that resemble the tumor cells. The fibrous capsule in this example is not very prominent. It is usually thicker. Here we can see the papillary pattern of growth where the tumor forms these papillary structures lined by neoplastic cells with a central fibrovascular course. It is not uncommon to see other types of growth. Here we have an example of glomeruloid structures that resembles normal renal corpuscles. Here we have a small area of solid growth, and here we have an example of tubular or acinar type of growth with a few foci that slightly resembles small glomerular structures. Very useful sign of papillary renal cell carcinoma is the focal accumulation of these foamy macrophages, also here and here. Alright, papillary carcinoma. Thanks for watching.
Application in the medicine. We performed comprehensive molecular characterization of 161 primary papillary renal cell carcinoma using whole exome sequencing, copy number analysis, messenger RNA, and microRNA sequencing, DNA methylation analysis, and proteomic analysis.
In terms of non-clear cell, yeah, that's the problem with non-clear cell patient because nobody wanted to conduct any clinical trial on them because the market is so small, and they have no options. So that's the problem with those orphan disease. We have good drugs for clear cell, and we'll continue to conduct trials, very promising trials on clear cell patients, and then we move as I mentioned, we move the median survival for metastatic kidney cancer patient from 1 year now to 3 years, and I think in the future could go easily up to 5 years. But those are for clear cell, but there's no company wanted to conduct trial because it cannot blame on a company because the patient population is very small. It'll be very, very difficult to finish any meaningful trial within a reasonable time frame. So that becomes very difficult. So we always have to, rely on the off-label use of something. For example, like we would really want to try PD-1 or PD-L1 that kind of immunotherapy on non-clear cell, but there's no trial specifically for that because we have 4 or 5 different trials on clear cell high-risk combination of immunotherapy, PD-1 antibody, PD-L1 antibody, CTLA-4 antibody, but we don't have any for non-clear cell. That's the problem. But good thing is that PD-1 is approved for melanoma and hopefully get approved sometime soon for kidney. Then we can utilize those. There are 2 types of papillary RCC. One is type 1, one is type 2. Type 1 is very similar to chromophore. It's kind of tend to be more indolent, but when they develop metastasis, they behave not as well. Type 2 is a bit more aggressive. Type 1 has been sort of hinted and related to c-Met signaling pathway. That's why MET targeting may offer some effective management of the disease. But having said that, we did a trial starting 2010, and it's now maturing. We do see a combination therapy in our hands show very, very promising results against papillary type of tumor, which leads to our expansion cohort that we're currently doing. And they may actually overthrow and become the standard of care very soon. Hopefully, they will benefit many of the non-clear cell, including papillary patients.
Pros and cons. Pros: type 1 and type 2 papillary renal cell carcinomas were shown to be different types of renal cancer characterized by a specific genetic alteration. Cons: MET mutation in type 1 tumors, CDKN2A mutation in type 2 tumors, CTD2, BAP1, and PBRM1 mutation in type 2 tumors, CpG island methylator phenotype in type 2 tumors.
For papillary cancer, for renal cell carcinoma, so there are two types. One is papillary type 1, the other one is called type 2. So type 1 actually has a higher frequency of a gene mutation. It's called MET mutation. So Dr. Shirari actually did a clinical trial with a MET inhibitor that showed some modest activity. But that c-Met inhibitor, according to his talk today, it's not a very pure inhibitor. So right now, I think they are planning to do another more pure MET inhibitor, and hopefully, this new MET inhibitor can have more clinical activity in this type of cancer. So right now, we are still relying on drugs that are for the common clear cell carcinoma to treat these rare types of tumor. But clearly they have different drivers of gene mutation for this rare type of kidney cancer. So by using one class drug on another class or other classes of tumors, that may work well. So I think as long as we track the biology of this rare kidney cancer, and design drugs to target these changes, the hope will be higher in the future. So. I think for clear cell renal cell carcinoma, I think the future is bright. So we already have quite a few drugs available for this common type of cancer. For rare tumors, they are getting more and more attention from the oncology field, and once the drug companies figure out, these agents can be, especially these immunotherapy agents, can be used for the common kidney cancer, and once they are approved by the FDA, it's very possible that they can be used for this rare kidney cancer. Because immunotherapy normally activates the immune system to attack cancer. So it doesn't care about which type of cancer it is. So I think from this standpoint, I think the future for this non-common kidney cancer is also brighter than before.
Issue applied in Ecuador represent 2 to 3% of all tumors, with a higher incidence in the countries developed and developing with an average age of 40 and 65 years. About 90% of kidney tumors are renal cell carcinoma, and the 85% correspond to clear cell carcinoma. Other histologies less common include papillary, chromophoric, and collecting ducts.
So this was actually the largest papillary RCC to date. We took over 100 patients with papillary RCC, gave them a drug called savolitinib. Savolitinib is a specific MET-only inhibitor, MET tyrosine kinase inhibitor, and has a safety profile that is pretty well acceptable. And why a MET inhibitor in papillary RCC? Now there is data. There is data from several sources, including the TCGA, that there's a subgroup of patients with papillary RCC, this rare really tumor. This is just a small subset of renal cell cancer. All what we talked about renal cell and the trial with IO drug are in clear cell. But papillary RCC is the second most common, still very rare, and we don't understand the biology. But again, few years ago now, we understand a subset of them do harbor alteration in the MET gene. MET mutation, MET amplification, and others, maybe around 30 to 40%, 50%, and these patients are sensitive to MET inhibitor. There was prior studies and there's a preclinical evidence. So we treated all of the patients with foritinib with metastatic, previously treated or untreated patient with papillary RCC. Now the response rate was low in the total cohort, 8%, but the only responders were the ones that had MET alteration. If you had MET alteration, response rate close to 20%. If you don't, 0%. The progression-free survival, totally significant. The tumor shrinkage, also significant if you have MET alteration. And so hopefully in the future, we will have a study, or at least we interrogate this drug that is well tolerated, doesn't have, the VEGF inhibitors toxicity, but in a population that have MET alterations.
Conclusion. Type 1 and type 2 papillary renal cell carcinomas were shown to be clinical and biologically distinct. Alteration in the MET pathway were associated with type 1 and activation of the NRF2 ARE pathway was associated with type 2 CDKN2A loss and CIMP. In type 2, conveyed a poor prognosis. Furthermore, type 2 papillary renal cell carcinoma consisted of at least 3 subtypes based on molecular and phenotypic features.
Kidney cancer care in 2015 really has boiled down to trying to calibrate and balance risk. And a lot of what this AUA offers its attendees is really an insights into how to better understand risk and how to better balance it. So first, when we see a patient with a renal masses, really we try to understand whether to treat them or not. And there are several abstracts here hitting on active surveillance. Really how to best calibrate active surveillance, what are the risks of active surveillance, and really when not to treat individuals with small renal masses. With that assessment of risk, what the urologic community is really trying to understand better is how do we understand and predict tumor pathology before we actually resect that tumor. And this will obviously help us to decide whether we need to resect the tumor at all. And basically there are two parallel efforts. One effort is in better utilization of renal biopsy, and there are several abstracts on that at the AUA. And then a separate effort is in really better is understanding how to better harness preoperative imaging in order to predict final pathology. And there's a really interesting abstract from Buffalo here where they take a look at cystic renal masses. And in general, these cystic renal masses are considered indolent, but there's certainly sort of wolves in sheep's clothing amongst those masses. And those are those type 2 papillary cystic type 2 renal cell carcinomas. And this abstract looks extremely interesting, where these investigators have actually quantitated solid components of these masses in order to and degree of enhancement in order to try to better predict whether this aggressive pathology is harbored within these cystic renal masses.
Thanks so much.